Hi, everyone. This is Amanda Jovog, the data lead for the County Health Rankings. Thank you for listening to the County Health Rankings Methods and Measures webinar. Due to unprecedented audio challenges during the live webinar, we have re-recorded this webinar for you. Let's get started. We want to start by acknowledging that the County Health Rankings and Roadmaps program is the result of the contributions of many partners, including the Robert Wood Johnson Foundation, our colleagues here at the University of Wisconsin Population Health Institute, and the various partners who help us compile the rankings data and get the message out about the rankings and roadmaps. So here's an outline of our talk today. We'll be going through some of the brief background about the County Health Rankings and Roadmaps, followed by an introduction to what changes and updates you can expect in the 2015 release. We'll then take a look at all of the measures ranked in 2015 with a brief discussion of some changes in data sources or definitions. The second half of this webinar will cover material we've discussed in prior years regarding the methods for calculating the rankings, limitations of data for counties, and a question and answer session. Okay, so this picture shows the thinking behind the rankings, our theory of change about how rankings can be a catalyst for action that improves the health of everyone in a community. We start with population-based data from a variety of sources. Then we use that data to rank the health of nearly every county in every state. The rankings take several different pieces of data and simplify them. They give communities a quick and easy snapshot of their health and of the many factors that impact how well and how long people live. Each year, the rankings release, which this year will be March 25th, generates national, regional, and local media attention. Some of you may have read or may have been quoted in stories about how your county compares to others in your state. This provides an opportunity for people to tell the story of the many factors affecting health in their community. Community leaders can and do use the rankings release to get the word out to their community and local media to help people understand the health status of their community. They use the findings as an opportunity to mobilize multiple sectors to look further at their community's strengths and needs. And based on this deeper look at their unique priorities, community members identify evidence-informed strategies that can be implemented locally to make change. Over time, these evidence-informed strategies ultimately result in longer, higher quality lives for all the children and adults in the community. With the county health rankings, each county across the nation receives two rankings: health outcomes, the current health of the community as compared to other counties within the state, and health factors, an estimate of the future health of your community as compared to other counties within your state. Counties are only ranked in comparison or relative to other counties within their particular state. Okay, so let's move on to what's new for 2015. Our updated website with new data and resources will be available to the public on March 25th. We're introducing a number of new features that will help you use your county's data to identify and garner support for local health improvement initiatives among government agencies, healthcare providers, community organizations, business leaders, policymakers, and the public. This year, we're making it even easier to find your county's data. Rather than just being able to access your county's data via the U.S. map or ranking search feature, you will be able to use the main website search bar. In the slide, you can see the result from our old search, where there's only 3 results matching Dane, none of which include the county snapshot, and the search results from our new search, which includes the county snapshot for your county at the top of the list. In our website, you'll also notice that the maps we use to display measure data will have a different look and feel. In past releases, we separated the county values within a state into 4 equal groups and used those quartiles for our maps. However, this year, to better highlight the magnitude of differences within states, we're using the distribution of underlying values, rather than groups with equal number of counties, to display more of the spectrum of values in a state. You can see in the maps above that the counties with particularly bad health values are colored a deeper shade of blue or green, and counties with particularly good health values are colored a lighter shade. We're also reorganizing the Using the Rankings data section of the website and introducing new content providing measure-by-measure guidance on how you can use external resources to find data on county health rankings measures by race, by age, by gender, or by even smaller geographic areas than counties. For example, in this new section, you'll learn how to access county-by-county quality of care data organized by racial groups through the Dartmouth Atlas of Healthcare, and how to calculate the rate of some college for census tracts in your community using the American Fact Finder. Now I'm going to briefly turn the mic over to Stephanie Johnson, one of our community coaches, to discuss changes you can expect from the Roadmaps to Health in this upcoming release.
Thanks, Amanda. Well, the Roadmaps to Health Action Center is going to have a new look in 2015. You'll notice in this image, this is our Take Action Cycle image, that work together and communicate have moved outside the circle to better reflect how important these elements are throughout the Take Action Cycle. We've also revised and updated the following guides: assess needs and resources, focus on what's important, choose effective policies and programs, and communicate. The remaining guides received a refresh. And we've also expanded our Roadmaps to Health community coaching program. 4 community coaches are based at the University of Wisconsin Population Health Institute in Madison, Wisconsin. And we now have 7 regionally based community coaches located throughout the country. So we look forward to supporting the work that you're doing in community. If you need help from one of our community coaches, there is a Get Help button on each page of our website, and we're happy to answer questions and support you in the great work that we know you're doing in community. I'm going to turn it back over to Amanda.
Hi, everyone. Okay, so now we're going to take a look at all the measures in the 2015 County Health Rankings. First, I'm going to go through how are measures selected. We often get this question. First of all, things that the County Health Rankings measure has to really reflect something that makes it different to population health, something that makes a difference that we can actually do something to improve. Any measure we choose has to address things that are actionable. We also look for data that is reliable, valid, recognized, and used by others. We don't collect original data ourselves. We rely on data that's collected by others. And we try as much as we can to get data that's regularly used and known to be valid and reliable. This is a very important feature for us. Next, since these are the county health rankings, we use data that are available at the county level. We get asked many times why we don't include one measure or another. The most common reason for this is that we are not able to access that measure at the county level. It's important to us that our data be either free or low cost. We always use the most current data available prior to our release. I'm sure that some of you share our frustration with the time that it takes for some of the measures to become available. Lastly, a key consideration for us is that we don't want to overwhelm people with hundreds of measures. Our experience has shown that fewer measures really turn out much better than having more measures. I also want to talk now about why we add new measures. First, we are committed to keeping the same health outcome measures. Those are the measures that measure the current health of our communities. We update them with additional years of data as they become available, but otherwise have made no changes to these measures since the ranking started in 2010. For health factors, we do change our measures if we find measures that reflect a better data source or a better way of calculating that measure, or more importantly, if we think they're really going to help us in our communication to communities about all the different factors that impact health. Decisions to add new measures have both a scientific component and also a communications aspect. All our new measures are proposed to and vetted by our scientific advisory group. So, our rankings are based on this model of population health. You'll see the health outcomes at the top in green and the health factors in the middle in blue. For this year's rankings, we've added one new measure to the income focus area, income inequality. Income inequality will join children in poverty as a measure of income in counties. This measure has been added due to the growing understanding that not only the average level of income in a county is important, but also the distribution of that income among households in a county. Our measure of income inequality is the ratio of household income at the 80th percentile to income at the 20th percentile. To illustrate how this measure is defined, here's a graph that shows the distribution of income in the United States in 2013. When the incomes of all households in a county are listed from highest to lowest, the 80th percentile is the level of income at which only 20% of households have higher incomes, and the 20th percentile is the level of income at which only 20% of households have lower incomes. If we divide the cutoff income for the 80th percentile, which is $106,101 in this example, by the cutoff value for the 20th percentile, $21,433 in this example, the ratio of 4.95 is an example of the income inequality measure we will be including in this year's County Health ranking. A higher income inequality ratio indicates greater division between the top and bottom ends of the income spectrum. The data for this measure comes from the 2009 through 2013 American Community Survey. You can see here that the range of values in U.S. counties go from 2.6 up to 9.7. While a small county in Texas has the highest income inequality ratio, the second highest county is New York County, the home of Manhattan, a place where both extremely wealthy and extremely poor households live. In an average U.S. county, the income at the 80th percentile is 4.4 times the income at the 20th percentile. So why are we choosing to measure this? As the gap grows between the poorest in our communities and those with the most resources, it affects how long and how well we all live. In communities with high inequality, everyone faces health risks and decreased quality of life. However, income inequality is particularly harmful to the health of individuals with lower socioeconomic status. For these individuals, limited resources can affect their ability to meet basic needs, such as paying for food, housing, or electricity, or access services that are beneficial to health. Inequalities in a community can also corrode the social connections, or how we relate to one another, and the sense of community for all of its residents. I'm going to move into talking about the remaining measures in our model. First, we look at the health outcome measures. They're divided into two focus areas, length of life and quality of life. We weight these two areas equally since we believe length and quality of life are equally important. There are no change in these measures, just updated data where available. All of these measures except low birth weight are age adjusted. For length of life, we measure premature death, and to be more precise, years of potential life lost. This measure is central to our work because it carries the entire weight for length of life. This data originates from death certificate information. It's based on deaths prior to age 75 with the belief that deaths under the age of 75 are premature and that many of them could be prevented. This year, our data was updated with 2 new years of data, going from 2008 to 2010 to 2010 through 2012. We also look at 4 measures of quality of life. Low birth weight, which we give a weight of 20%, and this also comes from the National Center for Health Statistics from birth certificate data. Then there are 3 other measures we use to look at quality of life that come from the Behavioral Risk Factor Surveillance System. There are 3 questions that are asked of individuals regarding how they feel about their health status. They're asked whether they're in poor or fair health, how many days in the past 30 days have they felt physically unhealthy, and how many days have they felt mentally unhealthy. We include these to stress the importance of quality of life and the importance of both physical and mental health. This is the core set of 5 health outcome measures we are committed to keeping the same over time, so you will be able to track a community's health status. Now we're going to move on to health behaviors. Here we include measures in 4 focus areas: tobacco use, diet and exercise, alcohol abuse, and sexual activity. We're continuing to use the same measures in all of those areas. At this time, I'd like to take a closer look at access to exercise opportunities. This measure was introduced last year to refine our measurement of the strength of the built environment for physical activity. In January of this year, a study was published in Preventing Chronic Disease, a peer-reviewed publication, with Annie Rubel, one of our data team members, as lead author. This study validated the methods used to develop this measure and its link to health. I'd also like to note a small modification for this measure. Our source of data for recreational facilities changed this year. This new source, Esri Business Analyst, is able to provide us with greater specificity in identifying the types of businesses that provide opportunities for exercise, and for most counties has created a more complete set of exercise opportunities. However, if you notice a substantial change in this measure this year, it may not be due to a number of businesses opening or closing, but rather to a change in the data source and definition. For clinical care, our measures remain unchanged. However, there's been a slight modification for the definition of mental health providers this year. This measure represents the ratio of the county population to the number of mental health providers, including psychiatrists, psychologists, licensed clinical social workers, counselors, and advanced practice nurses specializing in mental health care. In this year's release, marriage and family therapists and mental health providers that treat alcohol and other drug abuse were included. Access to care is obviously very important, but so is quality of care. Here we're able to provide county-level estimates for 3 different areas, courtesy of the Dartmouth Institute: hospital stays that could be prevented with better quality outpatient care, diabetic monitoring, and mammography screening. Moving into the social and economic factors. If you recall from our model, this is the section that actually has the highest weight overall. We assigned a weight of 40% to our measures of social and economic factors. We divide it into 5 focus areas: education, employment, and income each get a weight of 10%. Family and social support and community safety each have a weight of 5%. There's only a couple of changes in this area. First, we introduced the income inequality measure, as I described before. Income inequality will be weighted 2.5%, and the weight of children in poverty will be reduced from 10% to 7.5%. In addition to that change, you may notice that we have replaced our measure of social and economic support with a measure of social associations. Questions used to produce our earlier measure are no longer included in the core of the behavioral risk factor surveillance system. However, recognizing the importance of social and emotional ties within families and across communities, we felt it was important to search for an alternative measure from another source. Social associations use data from the county business patterns to estimate the total number of membership organizations available in a county per 10,000 populations. Associations include membership organizations such as civic organizations, bowling centers, golf clubs, fitness centers, sports organizations, religious, political, labor, business, and professional organizations. So now we're going to take a look at the physical environment. None of the measures in the physical environment changed this year. We continue to measure air and water quality, as well as housing quality and transit patterns. I'd like to quickly highlight our measure of water quality, drinking water violations. This is among the measures that generate the most questions from concerned communities. Drinking water violations is the percentage of the population getting water from a public water system that has at least one health-based violation during the reporting period. Health-based violations include maximum contaminant level, maximum residual disinfectant level, and treatment technique violations. Counties that were unaware they had a drinking water quality problem are often surprised to learn that a significant percentage of their county population were potentially exposed. We combined 2 years of data in an attempt to average out variations in this measure, but even one violation in a large community water system can lead to a substantial increase in this measure. Okay, since we value your time, we're going to split this webinar into two parts. The remaining portion of our of part two is going to be information about how the rankings are calculated and some special data issues that we repeat each year for this webinar. So we're going to move right into a Q&A session now and give you a little more information about some upcoming webinars if you're interested in those. So Stephanie, I think we have some questions prepared, some of which are from questions we received prior to our webinar and some of which we received during the live version of this webinar. So we're ready to answer those.
Thanks, Amanda. So you were talking about the different weights that were part of some of the measures, and you called out the social and economic factors and how that category had a higher weight measure. Can you comment on how you arrived at the actual weights for those measures?
Sure. Our weights for our measures are really we get a lot of feedback from many information sources. We do use analytic techniques to try and determine a measures and factor areas relative contribution to health. We also use literature to determine how other researchers have envisioned their contribution to health. And we also take into account the strength of the measure itself, the quality of the measure itself, and use all of those pieces of information to determine a measure of health, or determine a weight for our measures of health.
Excellent. Thanks, Amanda. There was a question that one of our participants on the live webinar wrote in and wondered if there's a way to compare data for 2 or more counties at once.
Yes. On our website, you'll find a feature that says compare counties, and you'll be able to compare as many counties within your state to each other as you'd like. You kind of just click or select the counties you want to add to your report, and you'll kind of be able to produce a snapshot that includes many different counties' values.
Excellent. What about the sort of distinction of measures changing from year to year? How can we measure change from year to year when the rankings also change?
Ranks are great for garnering attention, simplifying a lot of complex data, and making comparisons between one county and another at a point in time. But they shouldn't be used alone to measure a single community's progress. Rather, look at them as one tool among many. Because ranks are relative, they aren't as helpful in isolation. Your county's rank depends not only on what is happening in your county, but also on what happens in other counties in your state. In fact, if every county in a state improved its health, their ranks would all stay the same. One way of examining how much progress your community has made on its journey to better health is to look at the various individual measures in the county health rankings. We provide you with trend graphs for 11 of those measures, and that can give you some idea.
Excellent. Thank you. Can we go back to talk about the new measure of income inequality? And one of the questions that came in was, do you think counties with income inequality will see movement downward in their health factors ranking?
Sure, that's a really interesting question. Every county has a certain amount of income inequality within it. Those counties that have a higher level of income inequality may see a change in their rankings. However, we did, the weight assigned to that is 2.5%, which is a relatively small rank, or relatively small weight within the whole scheme of our health factors.
Okay, so as a community coach, I sometimes get this question from smaller rural counties. Can we look at data by areas smaller than counties? So for example, can we break things down by zip code?
The county health rankings currently don't provide data at the sub-county level. However, we encourage communities to consider the rankings a starting place for understanding their health and to look for opportunities to supplement rankings measures with local data. The County Health Rankings and Roadmaps website has additional resources under the Rankings tab using the rankings data that can help communities interested in using finer grain data to enhance their community health snapshot.
Awesome. And then sort of leading into that, can the rankings help determine public health priorities for a county?
Stay tuned for a webinar on using the rankings in your community on March 17th at 3 p.m. Eastern Standard Time, where we'll be exploring how communities have used the rankings data to engage partners through the media and as a starting point for community health assessments. We'll highlight tools that can help your community use the March 25th rankings release to garner attention and support in your community health improvement efforts. All right. Well, those were some great questions, and please feel free to email us with any additional questions. We're going to wrap up part one with just a little reminder about some upcoming webinars. As I mentioned, there's one on March 17th that will cover how to use rankings in your community. There's another webinar right after the rankings release on April 7th that is a County Health Rankings and Roadmaps 101 and a website tour of the new website. So please check out those webinars if you're interested. Okay, so that's the end of part